Hello all, this is Dr. Vince and welcome to this video on hypertrophic cardiomyopathy. If I tell you this topic is important for you in terms of your clinical practice because hypertrophic cardiomyopathy is one of the important or the common causes of sudden cardiac death in young patients. Now let's understand what is hypertrophic cardiomyopathy. So, as the name says, there is hypertrophy, but it is in the absence of. So, normally you see whenever the patient has hypertension, whenever the patient has aortic valve disease, or any infiltrative disease, or any metabolic storage disease, there is hypertrophy. But in this condition, there is hypertrophy in absence of any of these conditions. So, hypertrophy in the absence of hypertension, aortic valve disease, infiltrative and storage disease. Now there are no conditions related to these. So what is actually causing hypertrophy here? So in this condition, what is happening? There is defect in the proteins, sarcomeric proteins. Which are the proteins? So there is defect in myosin heavy chain. Now this myosin heavy chain is encoded by MYH7 gene, or there might be there are like number of proteins defective, but I'm telling you just the commonest ones. So the first commonest one, the first one is myosin heavy chain coded by MYH7. The second one is myosin binding protein C. So this is MYBPC3. This is coded by MYBPC3 gene. Now, what is happening because of the defect in these sarcomeric proteins? There is impaired function of the sarcomere. What happens when sarcomere starts malfunctioning? So, there is impaired contractility, and there is impaired calcium handling. Now, these conditions will actually lead to compensatory ventricular hypertrophy. Is this clear? Now, what is so special about HCM which is not present in other conditions? Okay, just see the first image. Let me use different color. So this is the first image is the normal one. Okay, here we have the interventricular septum. Now, if you see second image, what has happened here? There is hypertrophy. Can you see? This is the interventricular septum and there is hypertrophy of interventricular septum. So this hypertrophy is not symmetric. This is asymmetric septal hypertrophy. The first thing that you will see is asymmetric septal hypertrophy. Ash. Now let's come to third image. What is happening in third image? Now same, come back. This is the interventricular septum. Let me use different color. This is the interventricular septum. There is thickening of interventricular septum. Now what is just near to the interventricular septum? There, can you see there is left ventricular outflow tract. This is where aorta starts. So there is left ventricle. Now because of the hypertrophy of the septum, what is it doing? It is obstructing the left ventricular outflow tract. Okay, so the second thing that you see is left ventricular outflow tract obstruction. Now, come to the fourth image. So what is happening here? We'll again say the same thing. There is asymmetric septal hypertrophy. Can you see this? Yes. There is asymmetric septal hypertrophy. This septal hypertrophy is obstructing left ventricular outflow tract. Okay, now after left ventricular outflow tract, here you have the mitral valve. So now what is happening? The mitral valve is coming close to the left ventricular outflow tract and it is obstructing the left ventricular outflow tract. So this is called as systolic anterior motion of the anterior leaflet of mitral valve. So this is systolic anterior motion of mitral valve leaflet. Okay, so these are the three important things. Now what is ultimately happening? The blood flowing through left ventricular outflow tract has reduced. Now if this is reduced, what happens? There is reduced cardiac output. There is reduced cardiac output. It might also lead to heart failure. And because of the septal hypertrophy, this is interventricular septum, because of the septal hypertrophy, what might happen? The patient is more prone to ventricular arrhythmias. Now the ventricle is defective, therefore there are chances of ventricular arrhythmias. Now all the clinical features that you see in a patient can be related to this pathophysiology. So what are the symptoms of reduced cardiac output? There might be dyspnea. There might be syncope. Or there might be exercise intolerance. Okay, there might be reduced cardiac output, there might be symptoms of heart failure, left heart failure, and there might be ventricular arrhythmias. Just remember, ventricular arrhythmias is one of the important cause of sudden cardiac death in patients with HCM. Cause of sudden cardiac death in HCM. So is the pathophysiology clear? There are two important proteins which are defective. One is myosin heavy chain. The second is myosin binding protein C. Myosin heavy chain is encoded by MYH7 gene, and myosin binding protein C is encoded by MYBPC3 gene. So this is ultimately impairing the sarcomere function, which is leading to impaired contractility and impaired calcium handling. Now there are three important features that you will have to remember. So one is the asymmetric septal hypertrophy, then left ventricular outflow tract obstruction, then systolic anterior motion of mitral valve leaflet. This we call it as SAM. Okay. So these things, what they'll do, they will reduce cardiac output, or they might cause heart failure, or they might cause ventricular arrhythmias. The patient will come with dyspnea, syncope, or exercise intolerance. The patient might also have sudden cardiac death or features of heart failure. One of the important thing that you should remember is in HCM is the murmur. So whenever there is outflow tract, this is the left ventricular outflow, there is obstruction, you can listen to a murmur. And what is that murmur? That is ejection systolic murmur. Ejection systolic murmur. Let's understand more about this ejection systolic murmur. Okay, so it might be asked, it might be relevant for your practical, like clinical practice, or it might be asked in your viva about more about this murmur, like what are the maneuvers that will increase the intensity of the murmur or decrease intensity of murmur. For that, we'll understand few concepts. What are the factors affecting intensity of the murmur? So there are three important factors. One is preload. Okay. The second is peripheral vascular resistance. And the third one is contractility. So first, let's understand how preload affects intensity of HCM murmur. Now, what is happening when the preload is whenever there is increased preload, the ventricular volume increases. So if this is the ventricle, the ventricular volume increases. Now, when ventricular volume increases, what happens? Mitral valve leaflet moves away from left ventricular outflow tract. Away from left ventricular outflow tract. Therefore, what should happen? Because the obstruction is decreasing, so there will be decreased intensity of murmur. What is the example? Leg raising. So leg raising will increase the preload and which in turn increases the ventricular volume. Now when ventricular volume increases, mitral valve moves away from the left ventricular outflow tract and the murmur intensity decreases. Let's go to second condition. What happens? Same thing, like if the preload decreases, what happens? The ventricular volume reduces, mitral valve now comes closer to the outflow tract, and therefore what should happen? The murmur intensity should increase, right? Decreased ventricular volume, mitral valve leaflet moves towards left ventricular outflow tract, and therefore murmur intensity should increase. Increased intensity of murmur. Now, this is very important because sometimes you might be able to listen to a murmur in a patient with HCM and you want to confirm it. So, you need to know maneuvers which will increase the intensity of murmur. So, the maneuvers that will actually reduce preload will increase the intensity of murmur. Now, what are the things that might reduce? First is the Valsalva maneuver. Then sudden standing. So what happens in Valsalva maneuver? How do you do Valsalva maneuver? So you ask the patient to close the nose and mouth and then exhale. Okay. What happens whenever this is done? The intrathoracic pressure increases and the great veins get compressed. So now when the great veins are compressed, automatically preload is decreased to the heart. Now once preload is decreased, the murmur intensity increases. Example, Valsalva and standing. What happens in standing? There is peripheral pooling of venous blood. Therefore, there is reduced preload. Now, second, peripheral vascular resistance. What happens whenever there is peripheral vascular resistance? So, heart has to pump with too much of work, right? You can just remember if the peripheral vascular resistance increases, the flow across left ventricular outflow reduces. There is reduced flow and automatically there is decreased intensity of murmur. What are the conditions that will increase the peripheral vascular resistance? Your hand grip. Hand grip. Okay. The third one is contractility. If the contractility increases, the blood flow across the aorta increases and the murmur intensity increases. And if the contractility decreases, there is decreased intensity of murmur. This is very important for the treatment aspect. Okay. Now, we understood about the pathophysiology of cardiomyopathy, hypertrophic cardiomyopathy. We also understood about the important auscultatory finding that you see in patients with hypertrophic cardiomyopathy. Now let's understand how to manage patients with HCM. Now there are three important aspects that you will have to keep in mind. So first, concentrate on reducing the contractility and heart rate. What did I say? Whenever the contractility is reduced, what is happening? The obstruction reduces. Now, what else happens whenever the contractility is reduced? When the heart rate is reduced, there is sufficient time for ventricular filling. Now, once there is increased ventricular filling, what happens? There is increased cardiac output. Increased cardiac output. This will reduce patient symptoms. What all can be used? You can use beta blockers. You can use calcium channel blockers, which is verapamil. Now, despite using beta blockers and calcium channel blockers, if the patient is still symptomatic, then you can use disopyramide. Disopyramide. Now, in the second scenario, you have to, if the patient is having heart failure, then you will have to treat the patient for heart failure. Mainly, you will be using diuretics. In third condition, if the patient has, I told you, this is a common cause of sudden cardiac death in young patients. If the patient has high risk, like if there is history of sudden cardiac death in relatives, if there is history of syncope, there are certain criteria for increased risk of sudden cardiac death. And if it is there, then it's better to give the patient implantable cardioverter defibrillator. Okay. Now, for the first, reduce contractility and treatment of heart failure. If there is no improvement, you can also go for surgical. That is septal myomectomy. Septal myomectomy and septal ablation procedures. So this is about it. I'll just quickly recap you about them. Hypertrophic cardiomyopathy is hypertrophy in absence of hypertension or aortic valve disease or infiltrative or storage disorder. No, if these are not causing, then what is causing it? The sarcomeric protein defect, which are myosin. One second. Okay, which is myosin heavy chain MYH7 or myosin binding protein CMYBP-C3. So these are ultimately causing what? Compensatory ventricular hypertrophy. The important features seen here are asymmetric septal hypertrophy. Now this asymmetric septal hypertrophy is causing left ventricular outflow tract obstruction. This obstruction is further aggravated by what? Systolic anterior motion of the mitral valve leaflet, leading to reduced cardiac output, heart failure, and ventricular arrhythmias. Important thing is the murmur of HCM, which is ejection systolic murmur, which are the maneuvers that increase the intensity. Valsalva maneuver and standing. You can ask the patient to perform Valsalva maneuver. Valsalva maneuver will reduce the preload. Reducing the preload will reduce the ventricular volume. The mitral valve leaflet will come towards the left ventricular outflow tract and the murmur intensity increases. How do you treat? There are three important things. You have to reduce the contractility and reduce heart rate to improve the diastolic filling. If the patient is having heart failure, treat the patient with diuretics. And if the patient has increased risk of cardiac death, then you will have to use implantable cardioverter defibrillator. So this is about it. I hope you understood this. Thank you.